Direct Connection is made by MPT to serve all of our diverse communities and is made possible by the generous support of our members. Thank you. Live from Maryland Public Television, this is Direct Connection with Jeff Salkin.
Good evening. Welcome to your Direct Connection. We begin tonight with growing fears about Russia's threats to use nuclear weapons as part of its invasion of Ukraine. Joining us to answer your questions tonight, Gigi Gronval, senior scholar at the Johns Hopkins Center for Health Security. Professor, thanks so much for joining us. You've done work for the Defense Department on nuclear, chemical, biological threats. Let's start with nuclear because that is the saber that Mr. Putin has been waving. What, no doubt he might do it, but what is it that he might do?
Well, I think this has been something that we've all lived under this cloud, that the potential for a nuclear strike could happen for many years. I think a lot of people who are younger didn't grow up with this potential threat, but the potential for a nuclear weapon strike has been around for a long time, as we know. And what we would worry about is a smaller tactical nuclear strike on Ukraine. Hopefully, this is just saber rattling and not something that is actually something that is going to be actually deployed.
You're not here to talk military strategy, but the part that I don't get, not understanding the weaponry, the idea of a small nuke, it sounds like an oxymoron, but their manual is basically escalate to de-escalate. Yeah. And if you do something like that, the health effects, the lasting effects don't just stay localized, do they?
No, they don't, and that is the why the phrase "escalate to de-escalate" sounds so crazy. But then again, so does mutually assured destruction. So these are not situations that we want to be in at all. And I think that is why the administration has been so clear about what they will do and will not do. And because that is the way that things have to be when two nuclear powers are engaged in this kind of crisis.
You're an immunologist by training. For people who are searching online for iodine pills in Europe, even the United States, for the idea that it's somewhat protective against radiation, radioactive fallout, does that make sense?
It will help for some kinds of radiation, but not all, and the health effects will be much broader than iodine can handle. So I appreciate the doing what little you can, but this is something that is unfortunately much bigger than iodine can handle.
The concerning things are the size of the nuclear inventory in Russia, other programs, chemical, biological, but also the willingness to use these things. I mean, in terms of, I think it was a nerve agent poisoning of an enemy of the state, but in the middle of London, Western Europe, outside of Russia. And then the story today about some of the negotiators on the Ukraine side, supposedly negotiating a possible truce, potentially having been poisoned.
Yeah, so chemical weapons threats are not assassination attempts using chemical weapons are not a new thing when it comes to Russia. This is something that has happened a few times. You mentioned those examples, and we don't know exactly what the poison was that was reported today of the negotiators. But it does really make it challenging when you're thinking about who can negotiate in good faith if their safety is not guaranteed. So it's really very troubling, and I'm sure that we will learn a lot more. But there might be some unanswered questions just because there is not always a lab when you need it right there to be able to perform the analysis.
A lot of this stuff we haven't talked about since World War II, World War I, in terms of mustard gas. When we're talking about chemical agents these days in a battlefield situation, what are we talking about?
There are so many chemical agents. There are so many and so many types, and for many years, militaries have been developing them. So there is a treaty that that regulates what that the OPCW that bans the use of chemical weapons, and you have to has lists of what is allowed for industrial chemicals, what is allowed for for riot control agents, et cetera. Just like with the chemical weapons, it's a little bit, there's a parallel treaty that the Biological Weapons Convention, which prohibits any nation from having or using biological weapons. So it completely takes that class of weapons off the table. So these are the instruments, the norms that nations have been abiding by, with some glaring exceptions. And Russia has been one of those exceptions.
Let me remind our viewers, if you have a question for our guest, you can give us a call at the number on the screen or send an email to livequestions@mpt.org. Let's start with Jeff in Prince William County. Jeff, thank you for calling. Go ahead.
Yeah, I'm a military veteran, and I have a concern about this escalating into something further, even if they use a small nuke. From what I read, and this is just from newspapers, that all military exercises involving nuclear weapons have cascaded into further use. Can you confirm or deny that?
I don't know, Professor, if you're involved in the war games stuff, but what do you think?
I am not involved in any classified war games, especially not with nuclear weapons. But I can say that the concern of escalation is why the administration has been taking the steps that it's been taking, and I think describing what they will not do as well as what they will do, and why there is a line to deconflict any between the Russians and the U.S. But this is a decades-old issue that there are these extremely powerful weapons, and that we never ever want to use.
The last horrible category of things we want to talk about with you is bioterrorism. You wrote a paper preparing for bioterrorism. What falls under that category?
Well, for biological weapons, there's bioterrorism and biowarfare. Russia has quite a few times now violated the Biological Weapons Convention. So they've had a program to develop these weapons, which are not supposed to be developed or used. But soon after smallpox was eradicated from the earth, it's only in a couple laboratories now. The Russians launched a program to include smallpox in a biological weapon. So it's a little different from the other kinds of threats because there's so many different kinds of pathogens that could be weaponized. But that's, this, when it's used by a state, it's biowarfare. When it's used by a non-state actor, like what happened in 2001 in the U.S. and the Amerithrax letter attacks, that's called bioterrorism.
For something that would be communicable, does the COVID pandemic maybe put the brakes on that a little bit? Because, I mean, one thing we've seen is a complete inability of the world to stop COVID permanently at any border. I mean, we see the new variants going around. I think half of Shanghai is locked down at the moment. So anybody who would release something like this would find it blowing back in their direction at some point.
Yeah, so that has been the big argument why biological weapons of that type would not be used, but that is not necessarily the same calculus that some nations have used. Otherwise, they wouldn't have put smallpox in bombs like the Russians did. So thankfully, they were not used. So, I mean, this is, and different groups will have different calculus for how they see these weapons. So nations that have navies might have seen what happened to the U.S. The ship that had the big COVID outbreak, the Theodore Roosevelt. They might see that and say, "Whoa, that could have happened to us. That could have happened to our Navy." But a non-state actor could look at the same situation and say, "Oh, that's a way to take a Navy and to be able to attack it for a group like us." So it's definitely depends on where you sit, how you see the threat. And that's why nations have to continue to prepare for these things, even if COVID has demonstrated that how vulnerable we can be to a biological agent that's contagious.
Yeah, I was thinking in this war, we've already seen biological consequences and nuclear consequences without any sort of weaponry in those categories being used, right? I mean, you have Chernobyl, which has had more dust kicked up into the atmosphere. You had the nuclear plants in Ukraine that were bombed, and then you have COVID, and you have this mass movement of people, many of whom have COVID, right?
Right. Yeah, that is a big concern because, a lot of places do not have, and here in the US, we wish that the vaccination rate was much higher, but the vaccination rate of seniors is actually pretty good. Compare that to Ukraine. I think the vaccination rate for adults is somewhere around 25 to 30% before the invasion. So there's a lot of very vulnerable people who are sheltering in large groups, people who are leaving the country to go elsewhere. So it's not a good situation. And war and disease have always been linked, but and this is not likely to be an exception to this.
What's known about the Russians have accused the U.S. of operating a lab in Ukraine? What's known about that?
Yeah, so this has been something that the Russians have engaged in a lot of disinformation about over the years. There are laboratories that the U.S. government supports. Just a little history. Once upon a time, when the Soviet Union broke up, there were all these weapons facilities, including biological weapons facilities and research institutes, and we needed to demilitarize those labs and break up the munitions and get rid of the chemical agents. And so that big program over time morphed into, because a lot of those people who are the bioweaponeers of the day are long retired. But this program morphed into a public health mission where we get surveillance data so we can learn about what new diseases are coming up.
Dr. Gronvall, I'm afraid we're going to have to leave it right there. But Gigi Gronvall, Johns Hopkins Center for Health Security, very much appreciate your time. Thank you.
Thank you.
Joining us now for our Your Health segment is Dr. Mitra Wallin, a neurologist at the University of Maryland Medical Center. Doctor, thank you for joining us.
Thank you for having me.
March is Multiple Sclerosis Awareness Month. Tell us, if you would, about the condition, which obviously involves the nerves.
Right. MS, or multiple sclerosis, is the most common progressive neurologic disease of young adults worldwide. And it's an inflammatory disease of the central nervous system, the brain and the spinal cord. And it affects adults in their 20s. The mean age of diagnosis is 30 years.
And is it a lifelong condition?
It's a lifelong condition. We think it starts even well before the time of first onset symptoms, and it lasts throughout life.
Think of it as having periods of flares and remissions. Is that true?
That's true. There's three main subtypes of MS. The most common way MS presents is with relapses. So a rather sudden, usually over hours or days, change in neurologic function. Common symptoms include loss of vision, weakness, sensory loss, or clumsiness. And that usually has a course of a few days or weeks, and then it gets better. So the relapses come, and that's usually how it starts in most individuals. And over time, patients can start progressing and get worse with a slow smoldering increase in neurologic deficits over time.
How big a degree of disability does the average patient face?
So it's really variable and depending on where the lesions are within the brain and the nervous system. In some cases, patients can go several decades with fairly minimal deficits, and then others, if a deficit is in an area of the brain or spinal cord that is really important, they could be left with problems, significant problems walking or vision loss or difficulties with other coordinated tasks during the day.
Who gets MS? More men or women, different ethnic or racial groups?
It's a good question. And members of our group participated in a prevalence study across the United States. And at least when you look at all people with MS in the US, whites are most likely to get MS, and women are about 2 or even 3 to 1 odds more likely to get MS than men. So for every two women, there's at least one male that has MS. So the ratio is in favor of women. I will say, if you look at the new cases over time, we found that African Americans actually have the highest incidence rates for MS, which is a relatively new finding that's has been confirmed in 2 populations within the United States. And not well known even in the medical community.
Does that mean more African Americans are getting it, or or more African Americans are being diagnosed with it?
Maybe a little bit of both. I think that incidence, just as a concept, it's a number of new cases in a given year. So we've found that roughly 12 per 100,000 is the incidence rate for African Americans, where it's 9 per 100,000 for whites, and Hispanics is just under 9 at 8 per 100,000. So the number of new cases we're seeing are highest in African Americans. If you look at the whole pot of people with MS in the United States, whites still make up the majority of that. But for whatever reason, there's been an increase in African American cases, and part of it may be increased recognition or something else driving it with environmental risk that we're yet to discover.
Does this fit in the category of autoimmune conditions? Because there are other autoimmune conditions where the incidence and the prevalence are increasing.
That's exactly right. So MS can be considered an immune-based condition. In terms of what the specific driver is, the antigen is still unclear, but it is an immune-based disease of the central nervous system where the body is actually attacking itself. And it's much like thyroid disease or asthma or other skin conditions that you see the same kind of phenomenon. And these types of disorders are on the rise in both children and adults.
Tell me again about some of the signs that somebody might have this, the symptoms that people develop. And in the context of, because I understand they can be subtle at the beginning, and it's something that you might be inclined to ignore. But is that a good idea? Is it advantageous to find out early?
Right. It's a good point. I think sometimes, especially sensory symptoms, when individuals have arm weakness or leg weakness, or that's more tangible that when they're weak. But when there's subtle sensory symptoms like they're numb or they have some tingling on one side, patients and often tends to blow that off, providers, because it comes and goes. And so, especially if you get that kind of a symptom and involves the whole side of your body, your arm and your leg, it's probably good to get checked out by a physician. And I think there's other signs that are more dramatic, like loss of vision, significant coordination problems where you have difficulties using your arms and legs. But it's sometimes the subtle symptoms, and when a relapse comes, it may be there for a week or two, and then it gets better, and so people tend to forget about it. And in retrospect, we find that several years or sometimes decades, MS really started, and we could have potentially got involved at an earlier time point that may have prevented further relapses and progression. The teaching point and kind of the take-home message is that there are a lot of medicines that we have to slow the disease down, and these can be used to very effectively if they're brought on early in the course.
How does that menu of medicines differ from, maybe when you started practicing medicine?
So when I was training, there were basically very few medicines that were used to treat MS itself, and really since the mid 90s to the present time, there's been an explosion of drugs that have been approved by the FDA for MS. Now, most of these drugs are for the early stages of the disease. There's less we can do for progressive MS, but that's an active area of research right now. And so it's really important that we make an accurate diagnosis early and get people on medicines early. And also do the things we can do to prevent disease progression or increase the risk for more relapses.
Is there a role here for complementary kinds of medicine? I mean, you see vitamin D linked to everything, but I've seen vitamin D linked to this.
Right. So vitamin D has been studied quite extensively in MS, and so we know that people with low levels have an increased risk for developing MS. It also likely plays a role in the relapses and progression. So it's one of the things we do check to make sure people are in the normal range. Like a lot of things, sometimes people can take too much, so we want to make sure that people are in the normal range, and we supplement folks that have low levels and encourage also other activities like small amounts of sunshine to convert vitamin D and to get it in the normal range.
You know, I also saw something in doing a little research about this affecting a greater percentage of the population in Canada. Does that make sense?
So yes, it does. So there has continued to be a north-south gradient in North America. And so people that live in the northern latitudes tend to develop MS at higher rates than those in the south. And
is that a vitamin D thing, maybe?
So we're not sure if it's vitamin D. It may be also an infectious thing. There was a recent paper that got a lot of attention on Epstein-Barr virus. We know that viruses travel much more readily in northern latitudes. That may be part of it, but it's unclear what the major issue is. But geography is an important environmental risk factor for developing MS, and that's been true for decades, really, since it was the first epidemiology works were described back just after World War II.
What would you say are the biggest mysteries with the disease right now, and at the same time, maybe the most exciting areas of research?
So good question. I think trying to figure out what is the causal pathway and what turns this disease on. And I think that the work on the Epstein-Barr virus, other viruses, vitamin D, smoking, obesity, some of these are potential modifiable risk factors that we need to pin down and understand so we can help prevent the disease, but also ways we can actually intervene early and to treat the disease is very exciting, some of the techniques we have, but we want to be able to predict better and to be able to stop the disease for those that are progressing quickly, and to have more tools to do that would be very helpful. But there's a lot of great work being done across the board for this condition, and to try to do a better job of profiling people and put them on the right therapy that meet their needs and their own genetics, and be able to provide a path for really a cure to slow things down.
Is there a genetic component to this? Does it run in families?
It can run in families. The majority of cases are spontaneous, without a familial component, but 10 to 20% of MS patients have a primary family member that has, or multiple family members. So we think it's probably one of these complex genetic disorders. Probably the most important genetic loci is the HLA area, which helps to map the antigens for the immune system. There are probably several hundred other genes that have a smaller risk potential for developing MS.
Well, it's MS Awareness Month. I hope we've raised some awareness. If somebody has a concern, maybe they're feeling something, they're looking for help, what's the best place to start? Do you look for a neurologist as opposed to primary care?
So I think the first step is to go see your doctor, your primary care doctor, and if there's a feeling that there is something neurologic going on with a symptom we just talked about, weakness, numbness, loss of vision, problems walking, I think making a referral to a specialist, a neurologist, and in particular, if you suspect MS, to send a patient to an MS program or center that has expertise is the next step. So we're happy to evaluate patients at any time and address questions. So we hope that these types of messages get out to the general public, and that people get involved with the workup and are informed so they can give their family members and friends the best information.
Dr. Mitchell Willeen, University of Maryland Medical Center. Sir, thank you very much.
Thank you. Appreciate the interview.
And coming up Friday on State Circle, the latest on the shifting lines of the state's congressional districts. Join us for that Friday evening at 7. Now, for all of us here at MPT, thanks for watching Direct Connection, and have a good night.
Your health segments are a co-production of Maryland Public Television and the University of Maryland Medical System.
This program was made by MPT to serve all of our diverse communities.